If you have a blurred image during surgery, what would you do?
Rub my eyes to have a clearer vision.
I will ask my assistant to probably clean the microscope lenses.
Change the microscope bulb.
I would dim the OR lights.
I would probably scrape the cornea.
I would refer to an expert surgeon.
ENDOILLUMINATOR, machine made simple. The surgical approach in eyes with poor visualization is highly challenging. When visualization of intraocular structures seems inadequate under the operating microscope, a simple modification in the surgical procedure by having an ENDOILLUMINATOR can be the game changer. ENDOILLUMINATOR works on the principle of oblique illumination, wherein the eye is directly seen under the microscope with the light of the microscope switched off and the ENDOILLUMINATOR being held at an angle of more than 70 degrees externally along the limbus to illuminate the anterior segment structures. It improves visualization by providing a stable, stationary and diffused form of illumination. The illumination is based on a wide-angle approach resulting in low irradiance. Intracameral ENDOILLUMINATION reduces the light scatter and glare, maximizing corneal transparency and allowing safe and effective surgery. Since 1993, use of ENDOILLUMINATOR has been described for cataract surgery for visualizing the anterior capsular flap in hypermature cataracts, ENDOILLUMINATION guided irrigation and aspiration during combined 23-gauge sutureless vitrectomy, as well as ENDOILLUMINATED infusion cannula for bimanual anterior chamber vitrectomy has also been described. Handheld fibers exhibit smaller illumination angles. However, they are more focused. Current illumination systems consist of high-intensity light sources and single-use ENDOILLUMINATION fibers up to 30 G. Existing devices employ xenon, halogen, mercury vapor lamps or light-emitting diodes, LEDs, as light sources. Commercial systems available from Synergetics, Alcon Laboratories or DORC. Use of ENDOILLUMINATOR is described sparingly in anterior segment surgeries. During anterior segment surgeries complicated by hazy media, ENDOILLUMINATOR acts as an external light source, enhancing visibility of the operating surgeon, aiding in smooth performance, achieving better surgical outcome. Here, we describe a series of challenging surgical scenarios in which the technique of ENDOILLUMINATOR-assisted surgery was performed with ease. The first case is of scarred cornea, in which visualization of the anterior chamber and beyond was arduous. Even after debriding the epithelium, coaxial light of the microscope doesn't help much in visualization. This is where the ENDOILLUMINATOR comes to the rescue. It helps to visualize and implant a glued IOL. The next scenario is that of a post-traumatic cataract with iridodialysis. The ENDOILLUMINATOR helps us in visualization of the remnant iris while we use the piecemeal technique in different areas to refix the iridodialysis. It also aids in better visualization of the vitreous strands when dye is not used. Furthermore, it helps while passing the 9-0 needle through the iris during single-pass 4-throw pupilloplasty and cutting of sutures post-SFT. In the next case scenario of a failed PK graft, the role of ENDOILLUMINATOR is substantial as the opaque failed graft doesn't allow any coaxial light of the microscope to pass through, and ENDOILLUMINATOR helps in visualizing structures underneath. The ENDOILLUMINATOR also aids in the formation of Purkinje images, which guides the centration of the pupil post-pinhole pupilloplasty using the single-pass 4-throw technique. In this interesting case of an ACIOL with summering ring in which the haptics were stuck in the anterior chamber angles, ENDOILLUMINATOR assists in visualization and creating surgical iridectomy to release the haptic, and also while burping out the summering ring out of the AC and vitrectomy. In this case of glued IOL, where the haptic of 3-piece IOL broke, ENDOILLUMINATOR comes to the rescue and helps in finding the broken end of haptic and safely explanting the haptic and damaged 3-piece IOL out of the eye. The view of the P-deck graft is enhanced when the endo-illuminator light is added to the field. When we put off the microscope light and just use the endo-illuminator light at an oblique angle, it gives beautiful illumination and excellent depth perception. The comprehension by the surgeon of the graft orientation and the graft dynamics within the anterior chamber is much better, and the direction of the graft can be easily made out. The unfolding of the graft can also be carried out with just the end illuminator light alone, and this gives a very good clarity to the surgeon, as you can see here, as opposed to the microscope light, where it is very difficult to make out whether the graft is facing upwards or downwards. You can see here the visualization is improved as compared to a very poor understanding of the graft with the microscope light alone. In case of inadvertent trauma to the Descemet's membrane, it can cause Descemet's membrane detachment, which might be very small and can get unnoticed, causing long-term corneal edema. Endo-illuminator light, when falls at an angle, can help in the visualization of these small breaks in DM. Vitrectomy endo-illumination attachments are often available, which allow aspiration infusion and vitrectomy. Apart from the above scenarios, it can be used in cases of trauma, chronic degenerative changes such as Labrador keratopathy, bullous keratopathy, corneal dystrophies, PPP, glued IOL, surgical iridotomy. Endothelial contact should be carefully avoided throughout and positioned inferotemporally and supported by the assistant. The endo-illumination probe should not physically interfere with microsurgical manipulation within the AC. The endo-illuminator aided modified approach to such cases is highly feasible, practical and convenient. It can serve as a smart addition to our surgical armamentarium, as patients with concomitant pathology can still get good post-operative vision with this modified technique, helping achieve better results both intra and post-operatively.